Thank you, Michelle. This talk is, 10 minutes is a time that we set for a goal. What do we tell our fellows and residents? Time is not important, but certainly we can be good surgeons and fast surgeons, but you don't want to be a bad and fast surgeon. So whatever you do, just to do it properly and correct, and time is not that important. Some of these techniques were nicely covered by Dr. Santosh in his talk. Ptosis in any form is a challenging operation, and certainly the case that I demonstrated this morning is not a 10-minute case. So these are cases that are very carefully selected. Even master surgeons can be humbled with very simple techniques, but efficient surgery is predicated upon good anesthesia, patient cooperation if needed, hemostasis, and good surgical skills. So is 10-minute surgery for ptosis possible? It is. I think the less time that we manipulate and touch the tissues, probably this leads to a little bit faster recovery. And we want to keep our results the same. Just because you're doing a procedure in 10 minutes doesn't mean that you're expected to have less of a good result. Again, these are acquired cases. Probably congenital cases are not the best cases for this. The surgery is predicated upon the anatomy of this area, which is the conjoint tendon, where the levator, the tarsus, and the septum fuse, and that usually provides the key landmark for any of our external procedures. I'm just going to take one step back and discuss the physiology and maybe the thoughts of levator versus Mueller's muscle. So the traditional thinking is that the levator is the main lifter to the eyelid, and Mueller's muscle provides an additional 2 millimeters of lift. But based on some dissections, particularly by Hirohiko Kakizaki, I think what we're kind of now realizing is that the levator is still the main lifter, but the Mueller's muscle is the main attachment to the lid. We're always taught, well, the levator inserts on the tarsus, and that is the main attachment. But I think if you look at this broad attachment from Mueller's muscle, it's more of a dynamic, changing tension band that adjusts based on our emotions and how our sympathetic innervation innervates the eyelid. So it's very dynamic. It's constantly changing tension that we achieve. And another way to look at it is the levator is the locomotive that drives the train, and Mueller's muscle is the linkage between the locomotive and the rest of the train. And as patients age, this rubber band gets stretched out. And certainly that's something that we can address. So in answer to the first question that I asked is, which is more physiologic, levator or Mueller's surgery? Actually, if you think about it, tightening Mueller's muscle may make more sense in terms of how we actually bring the eyelid back to its normal physiologic state. This is the principle that Dr. Santosh talked about earlier. So this is Herring's law. If you see a unilateral ptosis, just make sure you manually lift the ptotic side. And if you look at the opposite side, you'll see that the other eyelid comes down. So this is a example where you may want to perform surgery for bilateral surgery case, even though you see the ptosis primarily on one side. So there's two procedures that I would consider for the 10-minute ptosis repair. One is a small incision levator surgery. The second is a conjunctival amelorectomy. So the small incision levator technique was described by Mark Lucarelli and Brad Lemke. This is probably 2 decades ago. There is a couple caveats with this surgery. You usually do not need to perform, or you should not perform concurrent blepharoplasty. So these are cases where you don't want to take additional skin. It's just ptosis only. They have to have good levator function, minimal sedation. This can even be done under straight local anesthetic. I typically don't sit patients up. I know this may be variable from surgeon to surgeon, but I find if they're awake, they're able to cooperate, I don't need to sit them up. Sometimes if they're sleepy or drowsy, I think sitting them up does wake them up and you get a little better view. So this is done through usually an 8 to 10 millimeter central incision. There are some contraindications if the lid is floppy, if they have floppy lid syndrome or excessive laxity. as you know, if you put 1 or 2 sutures, that's not enough to get good contour because you get a peak. So these usually have to have lids that are relatively not lax and fairly taut. Thin lid tissues are usually also not a good choice for this procedure. Anxious patients, patients with poor levator function are also not good choices. So once this central incision is made, the conjoined tendon that we talked about earlier is open, and then the septum is open, the levator is identified, and then we actually will expose the upper tarsal border, and we will place a central suture to adjust the contour and level. So this often is adequate for the entire ptosis repair as a central suture. Occasionally, if you need to, you can open up the incision slightly and put an additional suture in. So this is a video showing the small incision ptosis repair. So this is about an 8 to 10, 12 millimeter central incision. Skin incision is made. We use the monopolar cautery, which is good for hemostasis as well as dissection. This is exposure of the upper tarsal border, and then that's the grasping of the conjoined tendon where the levator and septum fuse. We open up that central pocket, and then you can see the edge of the levator aponeurosis. Once this is identified, we can actually place a central suture to advance that. This is a 6-0 proline suture. It's done in a horizontal mattress fashion, so this is the tarsal bite. And that's about the rough position of where we place the suture in the tarsus, the central third. We check underneath just to make sure it's not full thickness. And then we advance the other aspect of the suture, bring it through the levator, and we tie a temporary knot. And then we ask the patient to open their eye, and you can see that's a pretty good adjustment. So we are often asked, where do you set the lid in an awake patient? Do you set it where you want it? Do you set it a little higher? Or do you set it a little lower? Personally, for me, I go a little higher because when the orbicularis kicks in, it usually comes down about 1 millimeter or so, because we are paralyzing the orbicularis when we put the anesthetic in. So either at the level or slightly higher is what I shoot for. So if we get a good satisfactory level, we tie that knot off permanently, then we put skin sutures in. This is just shows the intraoperative adjustment, and then if the sedation level is high, we give them a moment for the sedation to wear off. These are some examples of the pre and post small incision levator procedure. So you can see without the need for skin excision, we make a little incision in the crease, and with a central suture, you're able to get very nice elevation and contour. As you all know, some patients will complain if you don't take any skin out. They will get some advancement of the dermatoclasis as you lift the lid. The skin comes down, so just be cognizant if you don't warn patients of that. For example, in this patient here, patient was happy with the lid level but complained about extra skin. So this is something we all have to take into consideration, that when you elevate the lid, the dermatoclasis comes down. They're not using their brows as much. You see the brows come down. So you have to warn them, we may need to take skin later. If it's something you think about in advance, then probably you can incorporate that into your incision, but you're gonna have to extend it. That's not a small incision levator procedure, or skin excision. Some of the complications Dr. Santos talked about: over-under correction, contour abnormalities. Wound dehiscence, I think, is pretty rare. Hemorrhage is also rare. Okay, let's talk now about the conjunctival amelorectomy. And you might ask, well, when do you use one or the other? I think for smaller amounts of ptosis, 2 millimeters, you can use the amelorectomy, if provided they respond to phenylephrine. If it's more than that, then the levator is your better procedure. And again, there's no reliance on intraoperative lid levels with this procedure. No need to wake the patient up or do any sort of adjustments. All your decisions are made before you do the surgery. Phenylephrine testing, I use it for unilateral cases because it usually gives you the patient idea what it will look like postoperatively. If it's a bilateral symmetric case, I don't test it all the time because I know I'm going to get a pretty predictable lift, and as long as both lids are ptotic at the same level, I'm going to do the same amount of surgery. So this is the phenylephrine effect here. which is useful for, again, unilateral cases. So the anesthetic for the conjumulars, it's either a frontal block or local infiltration. You evert the lid, and if I'm going to do an 8mm resection, I'll mark 4 millimeters of where I place the central traction sutures. So this is the lid everted. We can visualize the upper tarsal border. And these are skin marking pen with a caliper. I mark half the amount of resection, and then I place a silk suture into the central marks, and then you can see the levator, excuse me, the conjumulars gets folded over, so that's how we get half the amount, because we get both sides on either side of the traction suture. A clamp is then placed, and then we will weave a suture. So this is a brief video showing the conjunctival amelorectomy. Shows eversion of the upper eyelid. You can see the superior tarsal border. And then this is the, I'm just going to briefly pause here. This is the amount of resection that we usually plan for a conjunctival molars. Most of the patients fall into this 2 millimeters of ptosis, which is 8 millimeters of resection. So we mark half the amount, which is 4 millimeters in 3 different locations. We'll weave a 6/0 silk suture, just a little slip of conjunctiva. Then that gets elevated. And then the clamp gets placed just to the level of where the superior tarsal border is. The silk gets removed, and then this 6/0 proline is weaved underneath the clamp, back and forth, and we'll externalize that onto the skin surface so there are no exposed sutures on the conjunctival side. We perform our conjunctival molars resection, and then we tie that proline off externally. This gets pulled at about 1 week. These are before and after conjumulars in the left eye. This is one on the right eye. You can titrate it. If you only need 1 millimeter of lift, you can do a 4 millimeter resection. So the advantages of amelorectomy, there's relatively predictable elevation. It's very useful in congenital cases. It can be done under general anesthesia because there's no need for intraoperative adjustment. Just be careful how much conjunctiva you resect. If there's any conjunctival pathologies such as symblepharon, giant papillary conjunctivitis, any sort of follicles, just be careful. I would probably avoid that and do an external approach just because you're worried about scarring. I find sometimes congenital cases are a little bit unpredictable with molars, so I prefer to do the anterior approach. So in summary, predictable ptosis repair can be obtained in 10 minutes or less. Results should not come at the expense of time, but efficiency is helpful to both the patient and the surgeon. And again, thank you to the AIOS for inviting me to speak. Thank you very much.
Thank you, sir. I have a question for you.
Yes.
Which patients are suitable for this molarectomy procedure?
I would say the question is what patients are suitable. So I think 2 millimeters of ptosis, unilateral. If it's a bilateral case, I think bilateral symmetric ptosis without any conjunctival pathology.
About the LPS function, how much it should be?
Yeah, the question is about how much levator function. I think they should have at least good to fair function. If it's low levator function, I wouldn't do it. I would do an anterior approach.
Thank you.
If the phenylephrine test is negative, I usually don't. If it's unilateral and the lid does not come up with phenylephrine, I'll go external.
If the test is not positive, then you won't go ahead with the molarectomy process.
Correct.
Right?
Or if it comes up a little bit, then I'll do a fudge factor and I'll do more than what I would normally do.
But then you also said that in bilateral cases you don't do the test.
Not necessary in every case. Bilateral symmetric. I mean, if you have time, you can test it. But I think most of the time, if you get symmetric lift bilateral, the patient's not going to usually complain too much.
Okay.
So if you want to revise a case which has been done by molarectomy approach earlier, now you are planning to do an LPS for a residual ptosis. So will you go by the same normogram, or you could
I think if it's a re-op, from an external that you're repeating internal, I would keep it the same, yeah. Some people even talked about repeat Muellers. I don't like it because it takes too much of the fornix. So.
Said in a small incision, ptosis
Levator.
correction, levator, you did, if there is any contour abnormality, how will you take care of that thing?
So I try and correct it on the table. If there's a peak, or if it's too nasal or temporal, I can place a second suture. You can kind of slide the incision over a little bit, or you can extend it and put a second suture. So I try and, you know, deal with it at the time. I think the goal of keeping the incision small is kind of more of a, I guess it's kind of a goal we shoot for, but it doesn't necessarily have to always be 8 to 10. It can be a little bit larger. It just heals faster, and sometimes the incision is not even visible in these patients.